Welcome to Chapter 6. We'll be discussing drugs that affect the sympathetic nervous system. So that sympathetic nervous system is the fight or flight side of us. It's the one that's going to get everything kicked up and moving when we need to. So if we activate it, we get moving. If we inhibit it, we slow down. Norepinephrine is the neurotransmitter for the sympathetic nervous system, and it's stored in adrenergic nerve endings. When the nerve is stimulated, norepinephrine is released. Norepinephrine can be reused or destroyed in the nerve endings. So reused is also referred to as reuptake. So just keep that in mind because that is a name of a drug later on down the line in a different chapter. So norepinephrine and epinephrine, they're both adrenergic neurotransmitters, but there are some important differences between the two. Both norepinephrine and epinephrine stimulate many of the internal organs to increase sympathetic activity. Epinephrine can relax smooth muscle, but norepinephrine does not. Because of the differences and the response produced by norepinephrine and epinephrine, several different adrenergic receptor types have been identified. So that smooth muscle that we were talking about, that's especially important. Epinephrine relaxes the bronchioles, which are a smooth muscle, and that's part of the treatment of asthma, is to relax those bronchioles to stop the spasm. So, drugs that affect the sympathetic nervous system are called sympathomimetics or sympatholytics. Sympathomimetics stimulate the sympathetic system and again get everything moving. Sympatholytics antagonize the sympathetic system and take everything down a notch. So drugs including epi and norepinephrine are called sympathomimetics because they stimulate the heart and can cause relaxation of smooth muscle. Sympatholytic drugs that block the effects of norepinephrine and epinephrine are called adrenergic blockers. So let's see what else I can tell you about that. There are a couple different types of receptors. I think we're going to cover them. Yes, we're going to cover them now. They don't go too deeply into them. There are alpha-1 receptors as well as beta-1 and beta-2 receptors. Drugs including epi that will stimulate the heart and cause relaxation of smooth muscle are referred to as non-selective beta-adrenergic drugs. So they are not only doing one, they're doing both, stimulating the heart and causing relaxation of smooth muscle. Sympatholytic drugs that block the alpha effects of norepinephrine and epinephrine are known as alpha-adrenergic blockers. Drugs that block only the beta-1 receptors are known as selective beta-1 adrenergic blockers. Okay, that might sound a little confusing now, but hopefully it'll make sense once we get into the drugs themselves. On slide 9, there is a table that talks more about the receptor as well as the organ that it's found in, what the effect is of both epinephrine and norepinephrine. And keep again in mind, epinephrine can relax smooth muscle, norepinephrine cannot. So alpha-1, found in most arteries and veins as well as our eye. Epinephrine has the effect of constricting the iris as well as constricting the veins and arteries. So contraction of the iris. Norepinephrine causes the same exact thing. Alpha-2 receptors found in adrenergic nerve endings. Epinephrine effect, decrease release of norepinephrine. Same thing with norepinephrine. Beta-1, which is stimulation of cardiac muscle. Beta-1 receptors are on cardiac muscle. They're found in the heart. Epinephrine causes an increase in heart rate, force of contraction, and atrioventricular conduction. Norepinephrine causes a moderate increase in heart rate, force of contraction, and AV conduction. So those beta-2 receptors are found in our bronchioles. So think of them as the respiratory receptors. Okay? They're also found in the uterus and skeletal muscle vessels. Epinephrine causes bronchodilation, relaxation of the uterus, and vasodilation of those skeletal muscle vessels. Norepinephrine has no effect on these. Does not work on smooth muscle. So, moving on from that slide, alpha-adrenergic drugs. These are stimulators. Clinical indications are hypotension, so low blood pressure, and nasal decongestion. Norepinephrine is considered to be the parent or prototype of the alpha drug class, and The most important clinical effect is, of course, the probably the hypotension part. Nasal decongestion is more common, but when it comes to life-saving medications, somebody who's hypotensive needs to have their blood pressure brought up. These alpha-adrenergic drugs are going to be our best bet. So let's see. The reason it works for decongestion is because these drugs, again, constrict the blood vessels, so they're not letting all of that stuff seep out of the blood vessels, the fluid that would normally cause congestion. The main adverse effects of alpha-adrenergic drugs include hypertensive crisis, as well as cardiac arrhythmias. Increased blood pressure is what we're looking for, but sometimes it can be overdone and we can give somebody too much of a drug. The most common side effect of the decongestants is irritation of the nasal sinuses because they are topical, as well as rebound congestion if somebody uses them for too long. So on our next slide, slide 11, they cover drugs used to treat hypotension, as well as drugs used for nasal and ocular decongestion. You don't have to memorize all of the information in that chart, but I definitely would become familiar with the names. That way you can recognize a name and say, I know that is a nasal decongestant. I kind of know a little bit about it, I can look it up and find out more, but it's always good to be able to recognize names of medications. So, beta-adrenergic drugs, these are going to stimulate our beta receptors. The most important action again is stimulation of the heart, beta-1, and bronchodilation, beta-2. Beta drugs may produce central nervous system overstimulation, which can result in restlessness, tremors, or anxiety. And dopamine functions as a neurotransmitter in the brain and is also formed as a precursor in the synthesis of norepinephrine. When given as a drug, dopamine produces several cardiovascular effects, as well as can have effects on the kidneys. Normally it's used to increase cardiac output and renal blood flow, and this is important during shock. Again, on slide 13, they cover all the beta-adrenergic drugs. Non-selective at the top are dopamine, ephedrine, epinephrine, and isoproterenol, and our selective drugs at the bottom. Albuterol there at the top works on beta-2 receptors. That is usually only used as an asthma medication. It has no effect on the heart because, again, it's selective for beta-2. A couple of those listed there are the one that is selective for beta-1, which is our heart, is dobutamine. So moving down the line, epinephrine, which is our beta-adrenergic non-selective drug, is used in acute allergic reactions like anaphylaxis, where somebody is swelling up, they possibly have hives, and what that's going to do is open up the airways as well as prevent shock from happening, so keeping the blood pressure up and keeping the heart working, but most importantly opening up those airways so the patient can breathe. So alpha-adrenergic blocking drugs. Alpha-adrenergic blockers compete with norepinephrine and epinephrine at alpha-adrenergic receptors. They're used in the treatment of hypertension, and what happens is when the alpha blocker binds to the receptor, it prevents norepinephrine or epi from producing sympathetic responses. The main pharmacologic effect of alpha blockers is to cause relaxation of smooth muscle, and that includes blood vessels, thus the drop in blood pressure. So, the side effects seen from alpha-adrenergic blocking drugs are similar to an increase in parasympathetic activity because we have slowed down our sympathetic nervous system. So this would include constriction of the pupils, nasal congestion, and increased GI activity. Alpha blockers can interfere with normal cardiovascular reflexes that control blood pressure. Some patients experience something called orthostatic hypotension, which is where when they go from sitting to standing or lying down to standing, they're more likely to faint because their blood pressure can't quite adjust as quickly. That cardiovascular reflex is slower or not present necessarily, especially when first starting therapy. So we always, when we have patients start on the drugs that are listed on slide 15, we always warn them about this side effect. And again, a lot of these drugs do sound similar, which is good. So you'll want to become familiar with not the dose, but the use and the drug name. Beta-adrenergic blocking drugs. Beta-adrenergic blocking drugs antagonize the effects of epinephrine and norepinephrine at beta receptors. Again, there are selective and non-selective, and they're used in the treatment of chest pain and cardiac arrhythmias. So, let's see. Moving on to slide 17 is our list of our non-selective and selective beta-1 blockers, beta-1 being the heart. So if they're non-selective and they don't choose between the heart or the respiratory receptors, they can have an effect on patients that can worsen their asthma. So keep that in mind whenever you see patients on that top level of medications, carvedilol, labetalol, nadolol, etc. Okay? So adrenergic neuronal blocking drugs. These drugs interfere with the formation or storage of norepinephrine. With less norepinephrine, sympathetic nervous system activity is decreased. Examples include methyldopa, reserpine, guanethidine, and guanadrel. These medications aren't used too often. Methyldopa is used in pregnancy for hypertension. Reserpine prevents the storage of norepinephrine and causes vasodilation and the lowering of blood pressure. Guanethidine is also used to treat severe hypertension, similar to reserpine. And again, these drugs aren't used too often. You probably won't ever see them in practice. So that covers chapter 6, and we'll move on to chapter 7 in the next video.